Hello future doctors, how are you all? Welcome back to MedSteps YouTube channel. So right now we are doing internal medicine series episode 1. So I'm your Dr. Anand. So today we are going to start a completely new and very important journey in internal medicine. So a structured high yield clinical series designed by especially for medical students. So in this series we are not just going to memorize diseases, we are going to understand them like clinician and step by step from pathophysiology to diagnosis, from ECG changes to emergency management. Everything will be explained in simple and exam focused and ASCII settings and clinically practical way. So, and we begin this series with a very important and frequently asked topic, that is acute pericarditis. So a condition that often present as chest pain but can easily be confused with myocardial infarction, pulmonary embolism, or even musculoskeletal pain like costochondritis. In this episode, you will learn how to recognize pericarditis at the bedside, the classic chest pain pattern that changes with posture, the ECG findings that every examiner loves to ask, and most importantly, how to manage it step by step in real clinical practice. By the end of this section, you will be confident enough to not only answer exam questions but also approach a real patient with chest pain like a doctor. So, without time waste, let's begin our internal medicine series episode 1. Acute pericarditis. Pericarditis means, in simple language, inflammation of the pericardium. Okay, and the main common cause of acute chest pain, this leads to pericardial effusion and cardiac tamponade. So this is very high yield topic if you are preparing for FMGE or NEET PG, or if you are preparing for your end rotation examination or USMLE. This is very important topic. So first of all, we are going to see the definition. So what it means: acute pericarditis is inflammation of pericardium. So here we can see pericarditis is inflammation of pericardial sac around the heart. So here we have some pericardial sac. The pericardial sac will get inflamed. So here we have some different types. We can differentiate this pericarditis into um, four different types. One is acute, and in 6 it will be like acute pericarditis. Then after we can see that is incessant pericarditis, that is around 4 to 6 weeks. Next we can see that is 4 to 6 weeks to 3 months we can see. Next you can see that is recurrent pericarditis. Next chronic pericarditis, that is greater than 3 months. Okay, so this is we called pericarditis. Now in if you're seeing anatomical point of view, pericardium is the layer. We can see fibroids, pericardium and parietal serous pericardium. The pericardium space we can see like around 15 to 50 ml fluid we can see in pericardium. So the visceral serous pericardium we call that is epicardium. Okay. So next we can see that is causes. In this causes, we have one mnemonic to find the causes, that is we called I watch the heart. This is the main mnemonic for finding the causes of pericarditis. I means it will be like idiopathic, means unknown cause. Next, W means it's related to viral infections, example like Coxsackie, mumps, Epstein-Barr virus, cytomegalovirus, varicella, and HIV. Next, A means it's related to autoimmune problems like uh, connective tissue disorders like systemic lupus erythematosus, rheumatoid arthritis, polyarthritis, and nodasa. Okay. Next, we can see T means tuberculosis. Next, C means cancer, because some malignancy can cause pericarditis, and H means hypothyroidism. Next, T means trauma. Next, H means like recent heart attacks or like Dressler syndrome, and E means end stage renal diseases. Okay, like a patient will get uremia and end stage of renal disease. And A means like aortic dissection. R means like radiation, and some drugs we can see laterogenic drugs like radiotherapy, post cardiac surgeries, drugs like procainamide and idalogen, and post myocardial infections including Dressler syndrome and rheumatic fever. So these are the main causes for pericarditis. Next, we can see some common cause. Next, we can see some common cause, like most common causes we can see developed countries like idiopathic means unknown cause like viral, Coxsackie and echovirus, and developing countries. In developed countries, the tuberculosis can lead to pericarditis, and in special causes we can see uremia, autoimmune disease, and malignancy. Okay, so next we can see some risk factors, that is like recent viral illness, tuberculosis, and patient have any chronic kidney disease or myocardial infarction or connective tissue diseases and cancer and radiation therapy. So these are the things will cause um, pericarditis. Okay, so if you're seeing pathophysiology, how this patient will get pericarditis means it's infection of autoimmune injury because of uremia. Okay, if in blood if patient have more amount of uric acid, then it will cause pericardial inflammation, and we can see capillary permeability will increases. Then the fluid will accumulate inside that pericardial space. Next, we can see pericardial effusion. Then after it will impair the cardiac filling activity. Then it will lead to cardiac tamponade in severe cases. So next, we can see whenever patient have this pericarditis, they are very prone to get cardiac tamponade. So whenever patient getting pericardial inflammation, the patient will get pericardial effusion. Then after it will increase the intra-pericardial pressure. Then we can see compression of cardiac chambers and reduced ventricular filling and decreased cardiac output and shock. So next we can see some clinical features. The clinical features, we have some symptoms like classic presentation. The patient will get chest pain, like sharp chest pain. It may be pleuritic and often relieved by sitting forward. Whenever the patient is sitting forward, the patient will feel some relief. And we can see non-specific symptoms like non-productive cough and dyspnea, and flu-like symptoms we can see like fever. Okay, next, like retrosternal pain, pleuritic, words on inspiration, and words lying flat. And if this patient is relieving when sitting forward, the patient will get relief from pain. And it's like highly characteristic findings. Next, we can see some signs. If you're doing physical examination, you can see some important signs like tachycardia, fever, and pericardial friction rub, and tachypnea. And the most specific sign we can see, that is pericardial friction rub. Okay, so next we can see here, that is pericardial friction rub. The friction rub we can see, that is like a scratching high pitched sound, like best heard left lower sternal border, and when patient is leaning forward. And high yield, important point, that most specific physical finding is friction rub. Okay, so we have to know how to interpret it, how to listen that auscultation and everything we have to know, because whenever patient is leaning forward, that time you can easily hear that the sound will reduce that friction rub. Okay, so next we can see here, that is investigation. In investigation we have ECG. In ECG we can see some like widespread saddle shaped ST elevation. Okay, you can see here, that is ST elevation. It will be like this and like this. Okay, so that diffused ST elevation. Then after we can see the PR depression. So for example, if you are seeing this second lead, the PR will go depression. So this is, so the P and R will go down. So that is we called diffused the PR will get depression along with the diffuse ST elevation and the normalization, and we can see the T wave will become inverted. So the T wave inversion and then next we can see sinus tachycardia in common cases. The T wave may initially be prominent and upright and peaked, and atrial fibrillation and atrial flutter or atrial topics may occur, and PR depression is more specific ECG marker for pericarditis. So if you don't know about that diffused ST elevation, just focus on that PR depression. This is the main hallmark. Okay. Diffuse ST elevation, unlike like myocardial infarction, widespread ST elevation, no reciprocal changes, and PR depression present in ECG of um, pericarditis. So it's like widespread saddle-shaped ST elevation in a patient with acute pericarditis. Next, we can see that is blood workup. In blood workup, we can do some full blood count. Next one, urinary analysis. Then after CRP and ESR and troponin, the troponin may be raised. Okay, normally you can see here the ESR must be like less than 20 mm per hour. If it's increasing, you have to suspect patient have infection. Next, if you're seeing CRP, that will be like less than 5 milligram per liter. The troponin will be like less than 0.04 nanogram per milliliter. And WBC, we have to check. Okay. And if you're suspecting some viral caused pericarditis, we have to check viral serology and autoantibodies like ANA and rheumatoid factor anti-CCP if indicates, and thyroid function test to access for underlying causes if indicated. Okay. Next, if troponin is mildly elevated, means we have to suspect myopericarditis. Okay. Next, we can see here that is chest X-ray. The chest X-ray will be like usually normal, and we can see some large. If patient have large effusion, we can see water bottle like water bottle heart, like it show globular enlargement of the heart if there is presence of pericardial effusion, like large effusion. Okay, next we can do that is echo. Echo is the investigation choice for to confirm the presence of pericardial effusion and the tamponade physiology and ventricular functions. It will detect. Okay, so we can do echo test also. Okay, so next we have one criteria to find out pericardial effusion. The diagnostic criteria will be like greater than equal to of 4. If patient have this criteria, then we have to suspect patient have pericarditis, like typical chest pain. Next one we can see pericardial rub. Next we can see ECG changes. Next we can see that is pericardial effusion. Okay, so these are the diagnosis criteria. Next we can see how we can differentiate the test severity. So severity grading we have mild, moderate, severe and critical. In mild cases we can see no effusion. In moderate cases we can see like small or moderate effusion. In severe cases we can see large effusion. In critical cases we can see that is cardiac tamponade. So next we can see here that is high risk features. Next we can see here that is high risk features, that is like admission criteria. We have to hospitalize. We have, if patient have maybe fever like greater than 38 degrees and large effusion or cardiac tamponade, immunosuppression and trauma or anticoagulation use we have to see. So next we have management. In generally we have to manage that patient with bed rest, restrict strenuous activity, and we have to treat underlying cause, and we have to monitor vitals, and serial echocardiography we have to do. So in first line therapy we have to treat underlying cause. After that we have to start first line therapy, that is if you are, it's like acute viral or idiopathic, we have to start NSAID plus colchicine. Okay, this NSAIDs and colchicine is the combination, is the first line for patients with acute idiopathic pericarditis. This is the standard treatment. Or we can start some pharmacological management like drug therapy. We have to used like ibuprofen, like NSAIDs or aspirin. Okay, we can give ibuprofen like NSAIDs 600 to 800 milligram orally 3 times per day for 1 to 2 weeks if you are suspecting patient have acute pericarditis. Second one, you can give aspirin patient have like, and it's like it will work like NSAID like every 8 hours 1 to 2 weeks for post MI pericarditis, and it's preferred after MI. Next, colchicine. Colchicine we have to give like anti-inflammatory. It will work like anti-inflammatory 0.5 to 0.6 milligram. We have to give for 2 times per day for 3 months. It will prevent the recurrence of pericarditis. This is very important. Next, we can see prednisolone for corticosteroid in severe cases like 0.2 to 0.5 milligram per kg per day. We have to give only 1 time per day. Like autoimmune refractory cases, we have to avoid for routine use. Next, we can see that is pantoprazole, that is 40 milligram oral. We have to use for NSAID therapy and for this thing will help for gastric protection. Okay, so in simple, whenever patient coming with pericarditis, first line drug we have to give, that is ibuprofen, aspirin and colchicine. Okay, next in second line we have to give, that is when NSAIDs are contraindicated, autoimmune diseases present, then we can go with prednisolone or specialized, or we have to take some guidance from specialist and consultation. Okay, and we have some alternative treatment, alternative treatments, that is refractory cases, like it may require azathioprine and intravenous immunoglobulins or anakinra. It's like specialized directed therapies. Okay, so these are the things based on severity. If patient have mild cases, we can treat that patient in outpatient like NSAIDs and colchicine. In moderate cases, we have to admit that patient, we have to monitor with echo. In severe cases, we have to hospitalize that patient. Then after patient have tamponade, we have to do emergency pericardiocentesis. Next, we can see some complications. In complications, the patient can get a pericardial effusion and cardiac tamponade. So in cardiac tamponade, the patient will get like Beck's triad, that is like hypertension, raised jugular venous pressure and muffled heart sounds. This is a classic board exam and viva setting questions. Okay, next we can see sometimes pulses paradoxes, like while doing inspiration, that time the systolic blood pressure will fall like greater than 10 mmHg. So that is we call cardiac tamponade and severe asthma cases. Okay, so next we can see some how to do follow-up means after giving medication and everything. We have to use some follow-up parameters like symptoms. We have to check ESR, CRP, ECG, echocardiography, like at least after 6 weeks. Okay, so these are the things. So in this internal medicine series, the episode 1, acute pericarditis, we discussed everything. At last, I want to give some summary or important points. Pericarditis we discussed. So pericarditis means is a inflammation of pericardium, and we can see viral infection is the most common cause for pericarditis. And we can see chest pain improves when leaning forward. This is the main hallmark. And the ECG shows diffuse ST elevation and depression. And the echocardiography shows investigation of choice. And we have to give first line therapy for pericarditis, that is NSAIDs and colchicine. If patient have cardiac tamponade, is the most dangerous complication, we have to do pericardiosynthesis. Okay, so we discussed everything about acute pericarditis. So we will meet in our next video, next episode. Till the time, take care. Bye bye. If you didn't subscribe my channel, like, share and subscribe. I'm signing off. Have a nice day.